Good morning, good afternoon, good evening. It's Dr. Deshava with a short little review video for Chapter 5, Fluid Electrolytes Acid Beats. Okay, so the main gist of this is where fluids, where solutes go, what follows, what balances them. Okay, so let me give you once over here. Let me see if that's a highlighting tool. Hold on just a second. Yeah. So if this is a cell, okay, for the most part, sodium, which is a positively charged particle, and chloride, which is negative, will be outside the cell. And the positive and the negative balance each other. We have potassium, which is a positively charged ion, likes to be inside the cell. Okay. And then you have proteins, which are negatively charged. Haha, that's not half bad. So it's all about keeping this balanced. Okay. So not only do you need to keep the balance, but also we will move these ions if we are facilitating nerve signals or muscle signals. Okay, so ions in the body do a lot of things. And then calcium's a big one. We know that helps with heartbeat. Okay, but just to give you a little once over. So not only do these want to keep balanced, I think a good thing to remember is where sodium goes, water goes. Okay, it's one of the main drivers of water balance. Pardon me. So if we get a lot of sodium, for example, in our food, we will swell up because we will retain fluid because we want to balance those fluids. And where sodium goes, water goes to help balance it out to make it isotonic. That's a general gist of it. Okay. So if a lot of sodium would pour into the cell, water would pour into that cell, the cell would increase and burst. Right? If we lose a lot of the ions inside of this cell here, or a lot of the water, let's say a lot of sodium comes out of this cell, water will follow it and the cell will shrink. So we've got to keep a balance so we can keep cells the appropriate size. Okay? That's the general gist of it. So let's see what happens when, okay. I move on. That's a general gist. Okay, so total body water is about 60% of body weight in adults. Now, water is an excellent solvent. Not only does water dilute things, cushion things, it provides a slightly charged fluid to which ions can attach themselves. Water molecule has just this probably looks familiar. H2O, okay, has just a slight charge across it. Okay, oxygen has a little negative, hydrogens have a little positive. So suppose we have chloride here. Okay, just would form a super weak bond across here, right? And then sodium would go here. And what that does, because of the opposite charges attracting, right? It spreads substances throughout these solutions. So water is a great solvent for that purpose. Now, we have a cell, just to clarify terms, intracellular is inside, extracellular is outside, also known as interstitial fluid, okay? Intravascular would be in the blood vessels. Transcellular goes across. That's what all that means. Okay. So pediatrics, total body water is a little bit higher. Aging kind of just decrease with everything, right? With the ability to balance those fluids, retain water and whatnot. Okay, water movement between fluid compartments. Oof, try not to blow your mind about this. Let's try to keep it simple. Okay. Hydrostatic pressure is going to be just the pressure of water, of the fluid. And what I am drawing here is an arterial going into a capillary bed. And then the venule coming out. So we know arteries go away from the body and feed the tissues. We have the exchange of fluid and solutes at capillary beds, and there's tons of capillary beds. Okay, and you could think of an arterial as being a small artery. The way body blood flows is away from the heart towards these capillary beds throughout the whole body. We have the exchange of substances at the capillary bed, and then as we move into the veins, which will move back to the heart, we'll start to move fluid and very few solutes back in, okay? Hydrostatic pressure will push, because of the high pressure in the arteries, will push water and substances out, and not because we've pushed so many fluids out, we will draw water back in order to balance out the substances in these veins. That's what osmotic and oncotic pressure is. That's a basic gist of it. And this also gives us the basis of perfusion. Okay, if you have the appropriate heart rate and blood pressure, you're able to get what you need out into the tissues, feed the tissues, and then draw the waste and the excess fluid back. That's the whole gist of it there. If that doesn't make sense, let me know. Okay, so Starling forces is that net filtration, and forces favoring filtration minus forces opposing filtration according to pressure and oncotic pressure, or the concentration of those solutes and solutions. Okay, don't drive yourself too nuts with that. Capillary hydrostatic pressure is exactly what I just showed you. That ability to push out at the capillary bed, and we want that to be effective and efficient, of course. And then as we get towards that venous side, we'll pull water back in. If we're not able to do that appropriately, we can get edema. Okay? And then this explains the reabsorption favoring, is being able to pull that back into the venous system, and compared to the interstitial hydrostatic pressure, will be the ability of those interstitial tissues around that capillary bed to push it back in, but really it's going to be that oncotic pressure driving that. Okay, so we push fluid out at the beginning of that capillary bed, we draw it back in to help balance the solutions in the bloodstream to send it back to the heart. Okay, and here is a visual of that. And I'm just explaining it from the blood pressure into the tissues. Realize that there's a whole other system when we're dealing with the balancing of the cells and also with the lymphatic system. The lymphatic system is there to pick up excess fluid and take it back to the heart. That's a whole different system we'll talk about. But then we have fluid inside and outside the cell. Don't forget, I talked to you at the beginning about how ions help to balance that. We also will have a little bit of hydrostatic pressure, not much. It's going to be primarily ions that drive that. And then we have those protein pumps across that cell membrane, which help to balance out ions and fluids as well. Edema is the inability to get the fluid back into the venous system, to send it back to the heart. Some people don't do that, and they need to put on those very sexy compression hose. I wore those this whole time I was pregnant to keep, hopefully my veins from expanding. Knock on wood, so far so good. But sometimes you lose that ability to draw fluid back. The venous system starts to get a little inefficient as we get older. Same thing with the lymphatic system. Okay, so we have an increase in that capillary hydrostatic pressure pushing fluid out into the tissues, decrease in that plasma or the venous oncotic pressure, and ability to draw it in. Capillaries start to wear down. You start to get fluid out, and then the lymphatic system starts to decrease in its ability to draw fluid back as well. And that lymphatic system, I'm sure you know the basics of it, is another series of small vessels that draw excess fluid. It has a little bit of an immune response as well. And we draw that back. It goes through lymph nodes and back into the heart. We could get localized as well as generalized edema. Localized, there's a localized problem. Generally, as you know, we will have heart failure if we have generalized edema, left versus right side. And you get that pitting edema, which we're all very well aware of, I'm sure. There's a visual for you. Okay, we went through this. Sodium is the extracellular fluid cation. Chloride is the extracellular fluid ion. Sodium is a very big proponent, not only for that fluid balance, it helps with nerves and muscles and how they function. It's one of the primary ions that we use with that action potential. Okay, so we need to make sure we have enough sodium to make sure we can control our muscles and our nerves. Some basic acid-base balance. I'll explain acid-base in a minute. Membrane transport, cell biochemistry. Really, sodium, I want you to remember as one of the ions that we will use with with nerve and muscle contraction. Okay. Now, we have different ways that we can balance sodium and chloride. We have the renin, angiotensin, aldosterone system. Probably sounds a little familiar from A&P. So this actually will start in your kidneys, okay? And we'll go into it in depth in the kidneys. If the kidneys sense that there is too little pressure, there's little receptors in the kidney that can sense if blood pressure is getting too low, it will send a signal that goes through the blood. There's a lot of steps to it. We'll talk about it in the future. And eventually it does a couple of things, one of which releases aldosterone. Aldosterone leads to sodium and water reabsorption. Where sodium goes, water goes. If we retain sodium, we will retain water. It goes into the cardiovascular system. And remember that the cardiovascular system is a closed circuit. If we increase the amount of fluid, we will increase blood pressure. That's the whole gist of it. Natriuretic peptides, I'm sure you're familiar with this. It does the opposite. It's a sensor, and there's actually one in the brain, one in the heart, that senses when there's too much pressure, gets rid of fluid. Okay, so this should really be bumped under a little bit. Okay, water balance. Antidiuretic hormone is yet another way that we balance our water. This is secreted from part of the kidneys, and it will increase what it really means. It really should be spelled out there. Antidiuretic hormone. Antidiuretic hormone. Yay, something that makes sense. It'll increase water reabsorption into the plasma. We also just plain will get thirsty. You know, if you don't have enough fluid, you'll get thirsty. You'll want more fluid. You drink more water. Okay, and that is sensed by osmoreceptors, baroreceptors, and volume receptors. These are all receptors. They are all nerves which sense different things. Okay. Usually we just say baroreceptors, which is the sensation of pressure. You have one in your neck. If you've done carotid massage, that's a baroreceptor. Okay. Not only does it sense high pressure, which decreases heart rate and blood pressure, it senses if we are getting too little pressure in the cardiovascular circuit and creates thirst. This senses osmolality and osmolarity, and if we're getting too low in our solutes, we'll get thirsty and maybe crave salt. Okay, there's that system. And I'm blowing through these pictures because it's everything that we've talked about with a little bit of a visual presentation. Okay, isotonic is our normal, of course, you know. You guys probably run circles around me with this. Solution. Hypovolemia is too little fluid. Hypervolemia is too much fluid. You know, with hypovolemia, we'll get decreased size of blood vessels. You'll not be able to see them. You know, hypervolemia, we get edema potentially. Okay. Hypertonic is when you're And I'm going to kind of quickly go through these because I feel like these are probably things that you guys do on a regular basis. The balance of solutions. So hypertonic means there's too much substance in your solution. Hypotonic means there's too little substance in the solution, or you have too much water. So hypernatremia is going to be an increase in sodium. Here are the ranges. Here's the manifestations. I'm going to kind of go through it because I feel like you guys probably know this already, okay? And they go into hypovolemia, hypervolemia, too little fluid. In a slide or two, they actually repeat this, which I found a little confusing, just so you know. But I think you want to focus mostly on the higher levels of sodium, how that can manifest, what are the numbers, right? And you could either have an increase in sodium or a decrease in water. That's the general gist, okay? Hyperchloremia often occurs with hypernatremia. Hypotonic alterations can either be too little solute or too much fluid, okay? Generally, it's going to be too much fluid. Hyponatremia, I'll let you review that on your own. And you can see here they repeat that hypervolemia, hypovolemia, right? Okay, so just, and hypochloremia occurs with hyponatremia. So knows its signs and the symptoms and what those imbalances are. Potassium is K plus. That's what I was showing you earlier. Inside of this cell, not only is it important as an intracellular ion, it moves in and out of the cell to create that action potential to make muscles and nerves work, okay? And then after we have an action potential, it'll actually be shoved back into the cell with a sodium-potassium pump. So what we have across the membrane of the cell, so suppose we've had an action potential and now we have sodium and potassium on the wrong side of the cells, okay? If we have a lot of sodium outside of the cell due to an action potential, or if we just have too much potassium outside the cell that snuck out and too much sodium inside, what happens is the sodium potassium pump kicks in and reestablishes that normal of getting potassium back in and getting sodium back out, okay? And this actually happens through one of those protein channels that we spoke about, okay? So you have a protein channel, it'll rebalance sodium outside the cell and potassium inside the cell. Okay, so sodium potassium pump. What I really want you to remember is muscle contraction, okay, including the heart that potassium deals with, and also nerve conduction, okay? You can add that on there, nerve conduction. Okay. So if you have alterations in potassium level, you can have a lot of issues that you can have. There's a list of them coming up here. Changes in pH can affect that. All these different levels of aldosterone, insulin, and epinephrine can affect potassium levels. The kidney is a very efficient regulator of potassium levels. It'll sense if the levels are getting too high, too low. Okay, slow changes in potassium are tolerated better than acute. This is why people use potassium chloride to kill people, right? Because an acute change of potassium will cause the heart to stop beating. Okay, hypokalemia, hyperkalemia, I'm going to let you look through those on your own. Know the levels, know the manifestations and causes. Okay. EKG changes. So the basics of EKG you can see here. Okay. Normal kalemia would be normal potassium. You have P wave, QRS complex, the tall one, and then the T wave. And basically what that means, let me erase that, hold on, is with the P wave, the atria contract. With the QRS, the ventricles contract. And then this is where the ventricles reset. Okay. And then the atria actually reset during the QRS complex. But you can see with hypokalemia, you get a shallow T wave, and then what's called a U wave, an additional wave right there. Hyperkalemia, you get a really tall peaked T wave, okay? And the ventricles will be affected with that as well. And then your levels of ions get all out of whack, not good, okay? All right, calcium, most of it is located in the bone as actually calcium hydroxyapatite, necessary for metabolic processes. It's regulated by parathyroid hormone, vitamin D, and calcitonin. Let's go over those very quickly. The rest I think you can kind of review on your own. But I want to explain calcium is very important, not only for bone strength, you also use it for blood clotting, okay? Cell receptor function, transmission of nerve impulses, and muscle contraction. Really important in the heart as well. So if you don't have enough calcium, you will draw it out of the bones to use it in the bloodstream. That's why it's important to have the proper amount of calcium. With that, health-wise speaking, vitamin D is a super important part of the absorption of calcium from the small intestines. I'd like to add with that as well, K2 is another vitamin supplement that helps to absorb it from the bloodstream. So there are some theories saying that if we don't have enough vitamin D, we can't absorb it from the intestines from our food. If we don't have enough vitamin K, we can't absorb it from the bloodstream to the body. Okay, so I really think vitamin-wise, these are two super important vitamins. Okay, so those help to absorb it from the intestines, absorb it from the bloodstream, relatively speaking. Parathyroid hormone is a hormone that deposits calcium from the bone into the bloodstream. So if we don't have enough calcium in the bloodstream to allow the transmission of nerve signals and the muscular contraction, parathyroid hormone is released, comes from small glands on the back of the thyroid, and it will help to facilitate the release of that calcium into the bloodstream so we can have that muscle and nerve contraction. Calcitonin, they've actually found doesn't do much, but you know how research goes. 1 year it says this, 1 year it says that. So I always remembered it this way. Calcitonin, which actually comes from the thyroid, don't worry about it, puts it in the bone in. I know, so stupid. But calcitonin will help deposit it into the bone and just plain old pressure on the bone. You know, as people get older, I think it's really important to lift weights to deposit calcium into the bone. That's really what they're showing is the main driver. Okay, so memorize your values there. All right, so alteration in calcium. You can read through this on your own and its effect, hyperkalemia, same thing. Okay, take a look at that. Phosphate, okay, so if we look at, well, phosphate is one of the, sorry, they don't have what I was looking for. Main substances that helps to hold calcium in the bone as well. It'll work in collaboration with calcium, okay? It'll work in conjunction, same thing with parathyroid hormone, vitamin D, and calcitonin. If we need more calcium and phosphate in the bone, parathyroid hormone, calcitonin will deposit it. Vitamin D3 helps to absorb it. I think I need some more caffeine. Sorry, I'm losing it. Ugh. Okay, and parathyroid hormone will release it from the bones. Okay, so please read through those explanations. Magnesium is also important for the absorption and the deposition of calcium into the bone. A lot of people are deficient in magnesium at not a clinical level, but a subclinical level. Please review the hypo and the hyper. Okay? All right, I'm going to let you review that on your own because this tape's getting a little bit long, and I want to make sure that I review the gist of acid base. Okay, acid base, little wonky, okay? Acid base is very important to understand because we have a very small range. 7.4 is the basic gist. So 735 to 7.45 is kind of the range that our tissues should be at, okay? So this means interstitial tissues, bloodstream, not stomach, not digestive tract, right? The general gist of blood and interstitial tissues should be about 735 to 745. If it goes above 7.45, it's alkalinic. If it goes below 7.35, it's acidic, okay? So, and this could be driven by hydrogen ions, which are acidic, can also be driven by carbon dioxide, which is the gas that we expire. Okay, those are the primary things you want to think about. Now, in general, the main drivers for the balance of acid-base is our lungs and our kidneys. CO2 is acidic. If we get rid of too much CO2, we're getting rid of acids, we'll become more alkalinic. If we retain CO2, we retain more acidic substances. CO2 is acidic, we become more acidic. That's respiratory alkalosis and acidosis. Now, the kidneys will balance acid base with hydrogen ions and also what's called bicarbonate ions. And bicarbonate ions you've got probably somewhere in your cabinet. It's, bicarb. So the kidneys will help regulate acid base by either getting rid of hydrogen if we're too acidic, because hydrogen is acidic, that'll be excreted through the urine, or getting rid of bicarb, which is actually basic or alkalinic, okay? I know it's so confusing. So that's a general gist. Let's look at the notes, okay? So acids are formed also at the end products of protein, carbon, fat metabolism. That's going to be released primarily as hydrogen ions, okay? Just think of hydrogen as being acidic. So to maintain that normal pH, those acids have to be balanced. Okay, so we're going to primarily, they say the bones, we're going to primarily focus on lungs and kidneys as the main balancers of acid-base balance. You can also use buffer systems in the bloodstream. So you can keep the bloodstream in mind as a balancing agent. And we want to maintain that normal pH, okay? So there is CO2, carbon dioxide, we expire it, we breathe it out, okay? That's one of our gases. H2CO3 is going to be your chemical presentation of bicarb. Bicarb will help to buffer, okay? And we can actually create bicarb in our bloodstream to help buffer. Now, we have the kidneys as well that can secrete hydrogen ions, which is at H+, to get rid of acids, okay? So I know they're talking about volatile and non-volatile. I really want you to focus on the actual examples: hydrogen kidneys, bicarb kidneys and blood, CO2 lungs, okay? So there's physiological or chemical buffer systems, respiratory, renal, okay? Physiological buffer systems is going to be the blood, respiratory, lungs, renal, kidneys that we have spoken about, okay? So buffer system is a chemical system that we can use to buffer major changes in pH. This happens throughout the entire day. We're going to be balancing things out. We've got bicarbonate buffer system in the bloodstream, that renal, and then also the respiratory. Protein is a buffering system that we can include in the bloodstream as well, okay? Carbon dioxide plus water form carbonic acid, okay? So, oh, I'm so sorry. I think I said up here, I apologize, I didn't make these notes. This isn't bicarb, this is carbonic acid. My apologies. Okay, so if we come back here, I'll show you that. Where was it? Okay, so here is bicarb. Bicarb is HCO3 negative. Okay, that's a base. Hydrogen is an acid. So if we combine hydrogen with HCO3, these charges cancel out. This is all you need to know. Trust me, I will not get into more chemistry. We get that H2CO3, which is carbonic acid. Okay, that exists in the blood, and that helps to buffer things because it'll tie up hydrogen. This is a strong acid. This is a weak base. Okay, it'll combine and form a very weak acid, which is carbonic acid, which is really non-reactive, that H2CO3. So it binds up the really reactive hydrogen. Okay. So, oh boy, I find these notes very confusing. I'm not going to lie. Okay. So really focus on the lungs, the kidneys, the lungs with CO2, higher levels of CO2, more acidic, lower levels, more basic. And then the kidneys will balance with either hydrogen or bicarb. And it kind of works opposite each other. If we're too acidic, the lung or the kidneys will get rid of hydrogen and retain bicarbonate. If we're too basic, it'll get rid of bicarbonate and get rid of, retain the hydrogen. Okay, it works as a countercurrent system. The lungs is primarily carbon dioxide. That's what you need to remember. Okay. Which this is saying the same thing with the renal buffering. Okay. Don't worry about ammonia. That gets into a whole different thing. And then proteins have negative charges that contribute to the buffering system, but the main drivers will be in lungs and the kidneys, as we spoke about. Okay. Increase in hydrogen, more acidic. Decrease in hydrogen, more basic. Okay. Here is a picture of it. Here is renal compensation. Once again, hydrogen and bicarb. Okay, respiratory compensation in the lungs. So realize there can be damage in the lungs, which makes them retain CO2. For example, COPD, you retain too much CO2. What will that make the patient? It will make them more acidic. The kidneys will compensate by getting rid of hydrogen and retaining bicarb, for example. Let me give you another example. If the lungs are getting rid of too much CO2, somebody's hyperventilating, they've been injured, they become more or too basic, we'll get rid of bicarb in the kidneys and retain hydrogen. So it's that compensation mechanism. So these will compensate for each other depending on what's going on. If the kidneys are damaged, or better yet, a good example for when the lungs will compensate, ketoacidosis. With ketoacidosis, we get too acidic in the bloodstream, and we will try to get rid of CO2 to balance the pH in the body. That's a good example. I think those would be the primary ones that you would see as an example. Okay. Metabolic acidosis, primarily when they say metabolic, it'll be kidneys or bloodstream. Okay. Kidney damage or diabetes. So with metabolic acidosis, low pH, normal or low PCO2, if they're compensating. We'll see those with diabetic ketoacidosis. I would really think, I know this is hard, I know it's so hard, but I think this is what they'll focus on board-wise. That's my guess. You let me know if you take your boards, and they do. Metabolic alkalosis would be a high pH, high bicarbonate, okay? Excessive loss of metabolic acid. You'll see this with like vomiting, diarrhea, for example. Okay. Respiratory acidosis, kind of just went through this with you, but review that on your own. Okay. Well, I guess for me as well. I didn't realize this the last slide. So acidosis, low pH, high CO2, hypoventilation, like your COPDs. High pH, low CO2, alveolar hyperventilation. You see this when people hyperventilate. That's why they give them a bag to breathe in, so they can return some of that CO2 and balance out that alkalosis. Whew, okay, I know that's tough. If you guys need help with it, let me know. I hope I clarified it a little bit. If I didn't, we can review it. But the basic gist you want to get, CO2 in the lungs, okay? Are we retaining it or excreting it? We'll change the pH. And then hydrogen versus bicarb in the kidneys. Are we excreting hydrogen or are we excreting too much bicarb? We'll change the acid base. And also realize that if we build up acids in the bloodstream, that we can get acidosis as well. All right, that's it. If you need help, please let me know. Take care.